Good morning, everyone. We'll go ahead and get started with today's Grand Rounds. First, a non-Grand Rounds announcement. Virtual primary care, that clinic opened effective yesterday. We're very excited about that. If you have any questions, please reach out to Dr. Karen Chaco regarding that. For today's Grand Rounds presentation, we have Dr. Molly Brett, who's going to be talking to us about when less is more, deprescribing in clinical practice. I'm very excited for this talk. I feel in my education, always learned how to prescribe, but those conversations, the assessment, and those nuances with patients on how we actually deprescribe is an important skill to try to avoid doing unintended harm. Dr. Brett did her undergraduate studies at Yale, medical school at Harvard, and residency at Beth Israel Deaconess Medical Center. She works at the VA, where she teaches medical students, residents, in particular with the residents as the assistant director for their clinic at the VA. Interests of hers include clinical decision making as well as deprescribing, so this is a perfect person for this talk. In terms of questions, we're going to hold questions for the end. You certainly can put them in the chat as you go to save them, but we're going to hold questions for the end of the talk. With that, Dr. Brett, we'll turn it over to you.
All right, thank you so much for the intro. So I have no conflicts. I'm going to start with this cartoon. I feel like this really sums up the experience of practicing medicine today, as well as I'm sure patients would say the experience of being a patient. So if you can't read that, it says, at your age, people can get anxious about taking so many pills, but I can prescribe something for that. So I love talking about deprescribing. I think it's something that many of us don't really learn any kind of practical approach to how to do. And then also there's just a lot of nuance, gray area, and there's often no right answers, which admittedly can make it sort of a hard thing to teach. But I think that's sort of an area that many of us like to explore in internal medicine. So learning objectives for today. We're going to briefly define polypharmacy and identify polypharmacy-related harms, define deprescribing, and then talk about some of the enablers, some of the barriers and benefits of doing that. And then we're going to go on a few deep dives. So we'll talk about a loosely structured approach to deprescribing with a few deep dives into specific classes of medications. And then lastly, using the concept of time to benefit and appropriateness, we'll talk a little bit about deprescribing in patients with limited life expectancy. So a lot of different things today combined into one talk. Polypharmacy. I'm not going to belabor this. I think many of you, you see this in everyday practice, you know the harms, but just briefly, by convention, the use of 5 or more medications is historically in research studies what's been called polypharmacy. But for our purposes today, I like to think about the use of any inappropriate or unnecessary medications as polypharmacy. So even if a patient's on 2 or 3 medications and 1 or 2 of those is not indicated, that's polypharmacy too. And again, you all see the adverse effects related to polypharmacy day in and day out in clinical care. To briefly mention, cognitive decline, falls, drug-drug interactions, non-adherence, cost, even mortality. I do want to just highlight one study that I think is really telling both about the harms of polypharmacy, prescribing patterns, and deprescribing. So this is a little older study, 2003, took place in 4 primary care practices across Boston, looking at outpatients prospectively. They did a number of analyses to figure out which factors were most associated with adverse drug events. And after controlling for a whole bunch of things, what they found was the strongest predictor of adverse drug events was the number of medications taken, more so than the presence of any specific class of medications. And they found that rates of adverse drug events increased by 10% for each additional medication prescribed, which is really interesting and should really make us pause every time we're starting a new medication to begin with, sort of addressing this on the front end. Now, deprescribing. You'll see this is a really hot topic these days. There's, Canada sort of led this field, and they've had an active deprescribing network of pharmacists and clinicians for a long time. The US recently created its own deprescribing network. I mean, there could be people in the audience today that are a part of that, actually. That's really working on a bunch of different things. But one definition of deprescribing that I like is the process of identifying and discontinuing drugs for which existing or potential harms outweigh existing or potential benefits. all within the context of that individual patient's care goals, level of functioning, and life expectancy. So really, just to briefly reframe this is proactive approaches to medication management rather than kind of waiting for the harm to start happening to address it. So as we go into this, I think it's important up front to know, there's been a million studies within the last couple of years of deprescribing. What do we actually know that deprescribing interventions can achieve? Now, this is a hard thing to study because there are so many different things that go into deprescribing decisions, and the comorbidities of the patient are very hard to kind of take out of that equation. But here's what the research shows. First of all, we know that deprescribing interventions are successful at reducing the number of medications that a patient's taking, and we know that they can also reduce so-called potentially inappropriate medications, which has its own different definition. They decrease falls. So particularly focused interventions on things like psychotropic medications and benzodiazepines have been successful in decreasing falls in older adults. Deprescribing improves medication adherence. This is one that I think we can all, just thinking about patients in our own practices, relate to. Studies have shown that deprescribing interventions can decrease hospital readmission rates. The most compelling data on this actually comes from studies of deprescribing interventions in the inpatient setting, reducing subsequent admissions. It decreases healthcare costs, and that both refers to the costs that patients pay for medications as well as the downstream costs of managing adverse drug effects. Now, reduces mortality. This is a very hard one to study. There's some conflicting data on it. There's been a few signals toward reduction of mortality, but I would say the evidence on that's not conclusive. And as I mentioned, very hard thing to study. So lots of good things here, though. Now, probably all of you are thinking, as I even start talking about this, of the many barriers to incorporating this into clinical practice, which is busy for so many other reasons. So some of the barriers, there's actually been a lot of recent studies as well of what do people consider barriers to deprescribing, but some of this is just kind of intuition as well. So when it comes to patient-level barriers, one of the frequently cited barriers to deprescribing is the sense among clinicians that patients will feel like we're giving up on them, or that we don't care as much about them if we're recommending stopping medications. So just to kind of clarify that issue, there are a couple of studies looking at this. This is probably the most recent, a systematic review and meta-analysis of 29 studies, actually internationally, asking patients and their caregivers about how they feel about this prospect of deprescribing. They found that 88% of the patients were willing to deprescribe based on a doctor's suggestion, and just slightly fewer, 75% of caregivers were willing to deprescribe their care recipients medications if a doctor suggested it. So on the whole, most patients are interested in doing this. That very much mirrors what I see in my VA practice. There's actually these were, like I said, international. It's kind of interesting, actually. This really crossed nations in patients' thoughts on this. There was a Medicare study here in the US that asked pretty much the same thing and found that 92% of Medicare recipients were interested in deprescribing if the doctor said it was okay. So hopefully that, at least improves our thoughts on this patient-level barrier. Now, clinician-level barriers, this is where it gets really hard. The biggest one, in my opinion, and in surveys of doctors, is time constraints. This is a hard thing to do in a busy practice. I'm going to incorporate throughout this talk a few tips about how I really think of this not as a separate part of my practice, but really incorporate it into every day-to-day visit. Now, this is another big one. So fear of adverse drug withdrawal effects. There's a big difference, I think, cognitively in continuing a medication that either you or somebody else started decades ago, even if you know that med might harm someone. That feels different to us than stopping a medication with the knowledge that stopping of the med could also lead to some adverse effect for the patient. And the latter is often more concerning to clinicians than the former, which is kind of interesting. So there's that aspect of therapeutic inertia. We just feel more comfortable kind of continuing what's already going on. Studies have also shown that many clinicians don't feel like they have adequate knowledge of how to taper medications in a way that is safe for the patient. So we'll talk a little bit about resources for that. And then this is another big one, hesitation to stop a drug that was started by a specialist. Oftentimes we don't even know why exactly the medication was started. And so I would definitely encourage a lot of communication with specialists about this. I found most folks to be very receptive to discussing deprescribing, even if they're the ones that have kind of initiated the medication. So lots of potential barriers, but we will try to tackle a few of them today. So where do we start? How about a simple, easy-to-use algorithm to guide us in this process? So here's one. Here's another. These are both meant to be used for this algorithm for each individual medication on a patient's list. I think we can all agree these are really impractical. We cannot go through those in a clinic visit or a hospital setting. Okay. So where do I start? I think I'm going to show you my process through working through cases and sort of more of a loosely structured approach. And we will have some audience participation questions thrown in. So this is a case of a 70-year-old man. He has AFib, hypertension, sciatica, CKD, his GFR is 55, stable coronary artery disease, coming in for his annual. His only symptom at this visit is lower extremity edema. You can see his medication list here. So apixaban, aspirin, atorvastatin, lisinopril, gabapentin, and furosemide. And I put on there what the indications were. So how do we even think about a med list like this? First of all, I'll say this is not a terrible med list. There's only 6 medications on it. But again, I think there's a few inappropriate ones that we can try to get rid of. So here's how I think about my kind of structured approach to deprescribing. The first thing I like to very briefly think about is the individual patient's risk of drug-related harm. So what do we know about that? We know that there's a few factors related to medication regimen that contribute to the risk of adverse drug effects. Number of meds, as we already talked about, and then the presence of a few high-risk meds does increase that risk as well. So here in this talk, I'm going to kind of come back to focusing on sedating or sort of cognitively affecting meds, hypoglycemic agents, and blood thinners. And then patient factors. So cognitive impairment, advanced age, renal, hepatic dysfunction, those all increase the risk of adverse drug effects, as you might think. And then I also put here the patient values deprescribing. So when I'm trying to think about how much I want to prioritize deprescribing in an individual patient's care, if the patient doesn't like being on so many medications, I'm absolutely going to focus on that more. Okay, so that's the first thing I think about. The next thing I like to go to are any of their symptoms. I'm trying to think about my patient's kind of list of active symptoms. Are any of them potentially caused by medications? The residents that I work with tease me about this, that Dr. Brett always blames everything on the meds, but I truly believe that I'm often correct at that. And this gives you a quick win, especially if you're nervous about deprescribing or a patient seems anxious about deprescribing. To stop a medication that then directly improves the symptoms that they're experiencing really is a great way to start. Next, I scan the list for high-risk medications. So as I mentioned, things that affect their cognition, that could lead to falls, hypoglycemic agents, blood thinners. And then lastly, and probably the most nuanced category, is this idea of sort of inappropriate medications. We're going to go through a few examples of that, but things, for example, that no longer have an ongoing indication, that exceed the recommended duration of use, or that don't match that patient's sort of prognosis. Okay. So based on all that, like everyone to just kind of think about, and there's no right answers really in deprescribing, but which medication would you recommend deprescribing first for this patient? So I heard an aspirin in the room. I think I heard a gabapentin.
We have about 20 responses from the Zoom audience, and 5% said apixaban, 33% said aspirin, 64% said gabapentin.
Awesome. All right. So let's see. So there's no right answer. We're actually going to talk about a few of those answers as this case progresses. The reason that I highlighted gabapentin here is because symptoms caused by this medication. So the patient was coming in with lower extremity edema, a problem that we wanted to tackle in this visit. And gabapentin, as you may or may not know, we'll talk a little more about this, causes lower extremity edema in 8 to 10% of patients. I see this all the time, and it is a dose-dependent side effect. Okay, but we will come back to the aspirin, the second choice here too. So in this patient, just kind of to go through methodically, so he is at an increased risk of drug-related harm, his age and his CKD. He does have symptoms potentially caused by meds, so we're going to tackle that first. He is on a couple high-risk medications, the gabapentin, blood thinners, etc. And then he, I would argue, is on an inappropriate medication. So his gabapentin is prescribed for sciatica, which, as we'll talk about, inappropriate indication, and it's also an inappropriate dose. So I think a lot of people forget that as you go below a GFR of 60, in a patient like this, the maximum daily dose of gabapentin should be 1,400. We see higher doses than that all the time. And that's one reason I hate when this stays on a patient's list, because their GFR is going to decline and their gabapentin dose is often staying right where it was. So why do I say this is inappropriate indication? So just to highlight one resource that I think is a helpful one for deprescribing, some of you may have seen this, the number needed to treat.com. It really sums up the number needed to treat for various interventions, as well as the number needed to harm. And this one, this anticonvulsants, it's primarily referring to gabapentinoids. There have been randomized trials of gabapentinoids for sciatica and nonspecific back pain that did not show any improvement in symptoms over placebo. I think we forget that all the time. Certainly anecdotally, we have some patients that benefit. Whether they would have benefited from a placebo, hard to say. But the randomized trials really do not support use of gabapentin, even for the conditions that gabapentin is and gabapentinoids are recommended for. So postherpetic neuralgia, diabetic neuropathy, the number needed to treat is 8 to 12, depending on the condition. And the way that I think about that is, okay, so 7 out of 8 of my patients are not going to benefit from this, if any, which really gives you a great opportunity to consider deprescribing these medications. I would say when I really talk to patients about that, probably at least half would admit, yeah, I don't think this really has helped me. But it stays on the list. And then in terms of harms, these medications can be pretty harmful. We've probably all seen it, but the studies show dizziness and sedation in upwards of 40% of patients, gait instability, falls, the peripheral edema. Once you start to look for that, you will see this all the time. Severe COPD exacerbations. There's 1 or 2 studies in the last couple of years looking at that. We don't totally understand that connection yet. FDA warnings for respiratory depression and death, particularly when used with opioids, which again happens all the time. Lots of harms. Okay. And then this is an interesting concept that is talked about a lot in deprescribing, these prescribing cascades, which means actually kind of going back to that first cartoon. You prescribe a medication for something, and then a symptom arises, and not recognizing that it's actually an adverse effect of the first med, you add another med and another med. So gabapentin has one of the best described prescribing cascades in literature. So this is what it is. You give the patient gabapentin, they develop edema. You add inappropriately so, you add a loop diuretic to manage the edema. Then let's say they get hypokalemic, you add potassium, they get GI side effects. It can go on forever. It gives you an opportunity, actually, when you stop one med, to stop multiple. So for deprescribing, it's actually a real great area to focus. And this is just interesting. This, most of the research, like I mentioned, on these topics has come out of Canada. They actually were able to show clear evidence of a gabapentinoid prescribing cascade. So they looked at patients prescribed gabapentinoids, and then they followed them for the next 90 to 180 days, and they found that over that time period, patients with that initial gabapentinoid prescription were significantly more likely to then be prescribed a diuretic. So this is really happening in clinical practice all over the place. And again, that was dose dependent. So the higher dose of gabapentinoid, the higher likelihood of a diuretic prescription. It's interesting. Okay. So going back to another barrier that we talked about, people, at least in precepting residents, people are nervous about stopping gabapentin. How do we do that without causing rebound or withdrawal symptoms? You cannot keep a down titration regimen for every single medication in your head. So I wanted to show you guys this resource. It's called medstopper.com. It's also from a Canadian group of pharmacists, geriatricians, researchers who it allows you to input actually multiple medications, and it will prioritize them for deprescribing based on that balance of harm and benefit. But the part that I wanted to focus on, I don't expect you to be able to read all this, but it does show you a very clear strategy for down titrating any medication. So for example, for gabapentin, they go pretty darn slow. They give recommendations for if a patient is experiencing withdrawal effects, and how to change that taper as you get down to the lowest dose. So it's just a good resource to have in your back pocket in teaching, in your own practice, for how to feel comfortable doing this. Okay, so the patient is back. He feels better. You were able to stop his gabapentin and then his furosemide. What medication would you deprescribe next?
So for the poll, we have 92% saying the aspirin, and we have 8% saying atorvastatin.
Awesome. I love it. I absolutely agree with you. The aspirin is the next one that I would deprescribe. So now we're sort of in this category. He's not having symptoms caused by meds anymore. He's coming in asymptomatic, but he is still on some high risk medication. So I'm zeroing in on these blood thinners. And then, as I think you all are aware of, the aspirin is inappropriate in this case. So a brief deep dive into aspirin, because this is another one that I think we see all the time hanging out on med lists inappropriately, and it can absolutely cause harm. So here's just a few situations that we see where long-term treatment with aspirin is not recommended, but it tends to, like I said, linger. So in this case, this patient was prescribed both anticoagulation for atrial fibrillation and remained on aspirin for stable coronary disease. Because oftentimes the aspirin initiation happened, a decade ago when they first developed CAD, and then the AFib happens later, we often forget to stop the aspirin. Very clear data that that's what's recommended. In most cases, for primary prevention, aspirin's not recommended. And this, there's studies out there showing that something like 40% of older adults are still taking aspirin for primary prevention. So this is one where if you don't talk to your patients about it, you don't know if they're taking it over the counter, and it's going to remain on their medication list. As solo anticoagulation for atrial fibrillation, the American College of Cardiology strongly recommends against this because the harms are still present, the bleeding harms, without significant benefit from aspirin for preventing stroke. There's very few cases where doses more than 100 milligrams per day are recommended at this point, but every now and then, I see patients who are on 325 and nobody knows why. So at least decreasing it. And then lastly, every now and then, so after for secondary stroke prevention, dual antiplatelet therapy is generally recommended 21 to 28 days. And then you would go down to monotherapy, but sometimes again, with just fragmentation of care, you see dual antiplatelet therapy continue. So all good cases, there's nuances to all of these, but just kind of things to kind of trigger your interest, I would say, if you see these sort of situations hanging out on a medication list. Okay. All right. So we did deep dives into gabapentinoids, and aspirin. And now I feel pretty good about this patient's medication list. Hopefully you guys do too. So we got 3 of the meds off. Okay. Case 2, deprescribing antihypertensives. So this patient, 81 years old, he has COPD, hyperlipidemia, and hypertension. He feels fine, but he reminds you, as my own patients do very frequently, he does not like taking medications. And every visit he comes in wanting to know if he can stop something. Specifically, my patients really do not like taking their blood pressure medications for a variety of reasons. So this guy's blood pressure was 119/62 at this visit. He's not on a lot of meds. He's on inhalers for his COPD, atorvastatin, lisinopril 40 milligrams, and amlodipine 5 milligrams. And he's coming in wanting to know, is there something that can be taken off this list? So I would say in this case, he's not on any meds that have me particularly worried about symptoms or high-risk meds, but meds become inappropriate when they are in conflict with the patient's goals and values. And then this is a case where I would at least think about deprescribing because of that. So I don't know if any of you have ever looked at the literature on deprescribing antihypertensives. There's not a lot, but I'm curious, no right answer here. If you saw this patient, would you try stopping one of his antihypertensive medications? Maybe as the Zoom poll comes in, I'd say like in the room, if you do think you might try to stop one, raise a hand. So that's about 50-50 in the room. Love it. I love areas of uncertainty in medicine. And we'll see what the Zoom group says.
Zoom poll says yes, 58%, no, 24%, and not sure, 20%.
Great. I'm glad we're talking about it. I don't know that I'm going to have an absolute answer for you, but I will tell you guys how I think about this based on the literature. So the biggest and kind of most robust study of this exact question was the Optimize trial. It came out in 2020, so I feel like there wasn't a lot of attention to it because of other things going on. This study asked, is it safe to deprescribe blood pressure meds in older adults? They were looking at patients over age 80 who were on 2 or more antihypertensives. Most were on 2, were not patients who for the most part were on 3, 4, and 5 blood pressure medications. They had to have a systolic less than 150 to begin, and they had to have either the patient and their general practitioner had to have some reason that they thought deprescribing a med might be beneficial. Now, most of those were actually because the patient didn't want to be taking so many medications. Okay, so exactly the case that we're talking about. And what they did for all of those patients was randomize them to either stopping one blood pressure medication or continuing their meds as per usual care. They stopped the meds in the reverse order of what this was in England, what the NICE guidelines for how to initiate blood pressure medications. They pulled them off in the reverse order of that. Okay, so the last med to be removed in cases without like a clear other indication for certain medications was calcium channel blockers. Okay, and here's what they found. So this is at 12 weeks of follow-up. The mean blood pressure in the med reduction group was 130.8 systolic blood pressure, and versus 133.7 in usual care. So only a difference of 3. Now, this was an intention to treat analysis. 66% sustained the medication reduction at 12 weeks, versus there was, about a third that restarted primarily due to systolics greater than 150. So you could argue all day like that 3 millimeters of mercury, there probably is some small increase in risk associated with that. But that they actually sort of address that question by going forward. Yeah. Oh, thank you. Yep, that is reversed. Yes, the reduction group is 133. Flip those, apologies. And the usual care group was 130. So 3 millimeters of mercury higher with medication reduction. Okay, so small amount. So why would that not be greater? I mean, first of all, there were some patients that had to restart a medication, but there are other hypotheses behind this that have been voiced. So for example, it's possible that if patients have had well-controlled blood pressure for years, that there's some vascular remodeling that happens that actually kind of improves their blood pressure and allows them to remove meds. We also know that it can be hard to predict, which medications certain patients are going to respond to for blood pressure. And so oftentimes, you'll start a med for blood pressure, they don't have the response you want, and instead of stopping that one and adding another one, you just add the other one. So pulling off medications, you may actually be stopping meds that weren't benefiting the patient to begin with. Okay. But what I'm guessing you guys are all thinking is, so what are like the more long-term consequences of this? How did things look year after year, and were there cardiovascular outcomes, adverse outcomes associated with this? So they did look at that. They did a follow-up in 2024, looking at longer-term outcomes, and they found no difference in medication, in hospitalization or mortality in the med reduction group and the usual care group. Okay. 51% of patients at 4 years were able to sustain medication reduction. So another, small subset of patients had to restart their meds, but most patients were able to stay off. Okay. That was the optimized trial. Optimized 2 is just starting up right now. That's going to look at slightly younger patients, 75 and up, and even more kind of robust long-term follow-up for these, harder clinical outcomes. So this is just one study. There's been a few others. Most of them have been in nursing homes, though, not in community dwelling older adults. So I do look forward to more information about this. So how would I present this to a patient who's asking to reduce their blood pressure medications? Because this comes up all the time. So, I admit there's uncertainty about what happens for any individual patient when you stop these medications. About half of patients are going to ultimately restart a med, but in my opinion, a trial of med discontinuation for someone that really wants to appears safe, it appears reasonable to try, and it doesn't really appear to be associated with long-term adverse effects, as long as there is some degree of ongoing monitoring and a plan to restart the blood pressure medications if the systolic, in this trial at least, goes above 150 or whatever you decide with the patient. So I think it's reasonable. There's a few other studies that have looked at who's going to be most successful in stopping a blood pressure medication. So calcium channel blockers are the hardest ones to stop. There's the biggest increase in blood pressure after stopping those, whereas beta blockers, as you might expect, are associated with the highest success for deprescribing. Patients with lower on-treatment blood pressure have more success with this. Patients who are on a single blood pressure agent, interestingly, at least in one study, had better success with deprescribing than those who required multiples, which that I'm not totally sure I would have thought of intuitively. Okay. All right. So hopefully that at least helps give a little bit of framework for feeling comfortable with the trial of deprescribing antihypertensives with some ongoing monitoring. All right. I'm sorry, I'm losing my voice from a little cold from germy young children. All right, so we're going to move on to deprescribing in our more frail or limited life expectancy patients. So another case for you guys, 84-year-old man. He has heart failure with preserved ejection fraction, hypertension, diabetes on insulin. His last A1C was 8.6. He has mild cognitive impairment, osteoporosis, coming in to see you after hospital discharge for volume overload. He's feeling better, but he's relying more on his son for help with ADLs. So let's think about deprescribing for this patient. Oops. Okay, so which of the following medications would you say, and again, no right answers here, is least likely to benefit this patient?
Poll results, all four answers. So insulin at 15%, excuse me, insulin at 18%, at 22%, bisphosphonates at 35%, statin at 39%, and SGLT2 inhibitor at 4%.
Interesting. That's awesome. Okay. So again, this is one where, there's a lot of nuance. There's no absolute right answer, but here is how I might think about this. Okay. So when I'm thinking about the appropriateness of medications for a patient like this, who's frail, who's having new ADL dependencies, and probably, reaching toward limited life expectancy, I like to think about a couple of things. Well, I'm certainly thinking about his high-risk medications, which makes me worry the most about his insulin, despite that A1C of 8.6%. And then the other concept that I wanted to teach a little bit about here is the time to benefit concept when you're thinking about medications toward the end of life. So what is that? Okay, so time to benefit is the idea that it takes time to benefit from various interventions, including medications. I'm going to explain this sort of confusing looking chart. This is adapted from the UCSF ePrognosis website, which is another tool I wanted to highlight. They have some really nice charts on the time to benefit from various interventions. They also have some great tools for actually kind of prognosticating for your patients. So what this is showing, these blue boxes are showing the lag time to benefit, how much time it takes to start to benefit from an intervention. So for example here, bisphosphonates for osteoporosis, it actually only takes a year or so to start to see fracture reduction. Statins for primary prevention, those curves start to diverge around 2.5 years. SGLT2 inhibitors is for heart failure with reduced ejection fraction. I mean, it's pretty amazing. I think it was like in the realm of 40 days to start to see a benefit, which is wild. But the highlight here for the patient like this, and why I would argue that the insulin should be the first thing we target, despite his A1C of 8.6, is that it takes 10-ish years to see benefits, most of which are in microvascular outcomes from strict glycemic control in type 2 diabetes. Okay, so in patients like ours, we have to, and this is so hard to do, but we have to stop thinking about A1C targets and really start thinking about avoiding hypoglycemia and avoiding symptomatic hyperglycemia, which you really don't see until you, depends on the patient, but until you see, sustained blood sugars in the 350s, 400s and up, that's when you really start to see symptoms from hyperglycemia. Okay, so this is just showing what the American Diabetes Association says, that older adults with very complex or poor health, they acknowledge they receive minimal benefit from stringent glycemic goals, and that we shouldn't even have an A1C target for those patients. Now, a patient like ours, his A1C was 8.6, you may need to add some oral agent to sort of keep him out of that danger zone. And I decided to take out kind of some of the details of, recommended deprescribing for insulin from this talk, because it gets pretty, in the weeds. But if there's questions about that, we can certainly talk about it. Okay. So for that patient, my vote would be the insulin, I would say, really to thinking about avoiding harm and maximally benefiting him. How do we even talk to patients about this? I think once we start, time to benefit can be a confusing concept to even think about as a clinician. So how can we talk to patients about deprescribing in these situations in a way that feels relevant to them? So again, luckily we have some good research on this. I love this study. They talked to 835 older adults, and they kind of floated phrases to see which one felt most useful, relevant, what they preferred for a clinician explaining deprescribing. Okay. And they used these phrases for various kind of classes of medications, but they actually all kind of came back to the same preference among these older adults. So what they found was that phrases that really emphasize concrete harms and benefits were the ones that were vastly preferred by patients. Okay. And things like you should focus on how you feel now, or this takes extra effort for you, were really not preferred by patients. So here's the exact phrasing that they used, because I actually think having a few phrases in your back pocket for bringing these sorts of things up with patients can be beneficial. So they said, for this increased risk of adverse effects one that was so preferred, they said, given your age and health problems, I'm worried that you are at increased risk of side effects from this medication. Pretty straightforward, right? That's the one that patients liked almost, sixfold more than they liked the last one. The extra effort one that they did not like was, taking this medication requires extra effort for you. It's another pill to swallow, costs you money, and requires periodic blood tests. It's just interesting. I don't know that I would have guessed that was so, not what patients wanted. But I think the thought is maybe that feels more like being given up on than having a clinician really emphasizing for you as an individual, here are the concrete potential harms of this medication. Okay. So focusing on adverse effects and safety concerns is probably the way to go when talking about these more nebulous concepts of inappropriateness. Okay, back to our case. Our patient's now 86. He has worsening cognitive impairment. He's coming in to see you after hospital discharge for weakness and dehydration after a UTI. He was discharged with a chronic Foley catheter. He's dependent on his son for even more ADLs, and they're interested in deprescribing. They're sort of on board with that idea. Okay, so where do we go for a patient like this? A patient like this may be on 10 different medications, and it can feel overwhelming in a visit to start this process if you don't feel like you have some backup from guidelines, okay? There's not a lot of guidelines that incorporate deprescribing. That's actually one of the US Deprescribing Network's priorities, is having, as guidelines for professional societies come out, having them have a section on deprescribing, which I think will be amazing, but we're not there yet. So here's a guideline, a tool that I wanted to share with you guys, because I think it's really helpful to just make us all feel more comfortable and supported in stopping medications as a patient reaches the end of life. So this is called Stop Frail. There was a version 1, and then more recently they updated to version 2. This was developed by consensus, like a Delphi study, consensus among experts in these fields, pharmacists, geriatricians, et cetera. And these recommendations apply to sort of who you might think, okay? Patients with increasing ADL dependencies, severe chronic disease, frailty. I like to think frailty can be defined in so many different ways, but a patient like this who's getting hospitalized for illnesses that might not, lead to hospitalization, like a UTI for a more robust person, that is a signal of frailty, but it's also one of those, you know it when you see it, right? Another recommendation for who to use this in is patients for whom the physician would not be surprised if the patient died in the next 12 months. I'm not sure if any of you are familiar with this surprise question. It's actually been well validated as a way to exclude patients who wind up having longer life expectancies. So if you can ask yourself that question, you think that there's a pretty good chance the patient, or you wouldn't be surprised rather if the patient died in the next 12 months, they're probably not going to exceed that life expectancy. Okay. So that's who this is applied to, but I think it has good principles, even more loosely for patients with limited life expectancy. So how would this help us whittle this guy's medication list? Okay, so let's look at his med list, and I'm going to kind of highlight what this Stop Frail tool would say about these medications. Okay, so his atorvastatin, they would say, stop it. So we know that at the end of life, statin deprescribing actually improves quality of life without any decrease in survival. That's been studied within in patients with about a 1-year prognosis, both those who are on statins for primary prevention and secondary prevention. So we should feel confident in making that recommendation, in my opinion, for most patients. Okay. His lisinopril, as we talked about with blood pressure, interesting topic, still a lot of unknowns in older adults. But when you really think about frail elders within their last year of life, liberalizing a blood pressure target to 130 to 160, there's really no data to suggest that that's going to be harmful for people. Alendronate, so not only because there's a lag time to benefit for these medications, but also there's this legacy effect of bisphosphonates. As you probably know, part of why we can do a drug holiday with these medications is because the beneficial effects last for years even after you stop it. So absolutely reasonable as you're really reaching this limited life expectancy to stop that med. Tamsulosin. So for a patient like this med hangs out on medication lists in chronically catheterized patients all the time, and there's absolutely no indication. Stop Frail also has great recommendations about overactive bladder medications. As patients become incontinent, there's really not much benefit for those either. So another one that you can often stop in these situations. And then the patient was on calcium carbonate, vitamin D, and multivitamin, probably shouldn't have been, but these guidelines really clearly highlight the lack of evidence for those sorts of interventions, especially in somebody at the end of life. Okay, so we could feel, I believe, if the patient and the family members were on board, we would have some kind of backup, I guess I would say, in stopping most, if not all, of the medications on this list. Okay, all right. So a few final pearls, and then I know that I can see from the chat there's some questions, which I look forward to answering. So I mentioned at the beginning, starting this process with a quick win if possible. If there's a medication that is causing symptoms, go ahead and try to deprescribe that one first. Gets everybody feeling good about deprescribing. Offer deprescribing as a trial off medications that could be restarted as needed. So I think we often talk about a trial of medications when we're initiating meds, but we might not use that same language in deprescribing. And I think it's really important for the patient to know explicitly that this is not going away forever necessarily. I mean, obviously something that's incredibly harmful is a different situation, but that this is an ongoing communication with the clinician, okay? Using visual aids like pill bottles in hand is so satisfying during this process. And so it helps you kind of just visualize how much of a medication burden this patient is experiencing. But beyond that, I have a Sharpie in the room and I put a big black X on the medications that I want the patient to stop. Otherwise, I have found that 30% of the time the patient comes back after a deprescribing visit and they're still taking the medications because they got confused. So definitely having it right there to kind of cross off the meds that you don't want them taking. Remember that it's fine to go slow. So when we looked at that gabapentin down titration recommendation, that can take months. And sometimes, let's say you don't have the availability to follow up with this patient. Maybe you don't have a pharmacist or a nurse to help you check in on them. You might not see them for 6 months. If you down titrate meds every 6 months for a couple of years and you get them off a medication, in my opinion, that is still a win. And I think the patients would also agree with you that that's still a win. If this happens slowly, oftentimes that's better for the patient's comfort, and it's still a deprescribing intervention that I would support. And then lastly, and this is the one that I really, really like to do, for patients where I'm worried about polypharmacy or where the patient is worried about polypharmacy, I have that as an explicit element of my problem list. And I keep it on there, that I'm updating, oh, this is what we're doing for their hypertension. This is what we're doing for their polypharmacy. Sometimes it takes 2 to 3 years to actually have a visit with the patient where there's not so many other competing concerns that I get to talk to them about the polypharmacy. But I have it as a trigger to myself, and I kind of have already thought out how I might go about doing this for the patient. And so at least I am always knowing, I'm always recognizing that this is a worry. And also if others, if specialists, et cetera, are reading my notes, which maybe they don't, they also know kind of what my thought process is there. Okay, so I find that really helpful. Okay, so I am going to stop there. Happy to take questions.
I'll start with one from the chat and then I'll turn it over to Mark. So we've got quite a few in the chat. The one I'll lead out with was you had the study that showed ways to communicate to patients about deprescribing, and the one they liked the most, the one that resonated with them, was about adverse events. And so Apoorva said, I often get, but I don't have any adverse events, or I don't have any of those side effects right now. And so the question is, do you have any recommendations, methods for addressing that for that next step there?
Yeah, great question. And actually, interestingly, one of the meds highlighted in that study was a statin, which I think is interesting because most patients we know don't really have major adverse effects from that. So I think if you want to make sure that you're kind of feeling honest to yourself for something like a statin deprescribing, I think emphasizing that weighing of harms and benefits. And if you phrase it that way, certainly there can always be a harm from medication, whether in your mind you know that the harm is having to take more medications, pay more money for medications, et cetera. But the benefits are decreasing. So one way to kind of phrase that is more about the balance of harms and benefits than you're actively having harms. And then I also definitely think that patients have seemed, because I talk to them about this stuff all the time, pretty receptive to this idea that your kidneys probably don't work quite as well as you get older. Your liver probably doesn't work quite as well as you get older. That can lead to differences in how we experience medications as you age, that might down the road mean that this medication could be more harmful for you. So I found those phrasings to be helpful, but if anyone else has other ideas, I'd love to hear it.
So thanks for a great talk, Molly. My question related to the hypertension,
Yeah.
and I often have the experience of prescribing a third medication and the blood pressure never changes.
Yeah.
And so I wonder about the sort of seemingly paradoxical response they found that blood pressure improved with deprescribing,
Yeah.
and whether that's in fact you see better adherence and is there any data to suggest that?
Yeah. So I had those incorrectly flipped. So the blood pressure, it was a 3 millimeters of mercury worse in the deprescribing group, but not a huge difference. Yeah, this is not an area that is fully understood. I mean, in general, deprescribing does lead to improved med adherence. So that is one possibility that maybe they just kind of gave up on taking the meds, but once they're on one, they'll take it. I mean, that's also part of the argument for the multi-pills, right, for blood pressure management. But yeah, I mean, I think there's still limited understanding of exactly which patients are going to respond best to which medications. And so I do think that there is a possibility that some subset of everyone who's on multiple blood pressure medications, some subset of those are going to be less beneficial. And I did think part of what was interesting about some of the research that we have on that is that the calcium channel blockers are the hardest to successfully stop, which does kind of fit with my experience too.
To tie together some comments and a question from Annie and Christine. So comment on there's a high number of over-the-counter supplements that many patients, including younger patients, are taking, such as peptides, creatine, herbal products that could be part of deprescribing. Christine said, I see a lot of stimulants being prescribed for questionable ADD, ADHD, when symptoms could be cognitive impacts of meds, for example, the gabapentin. And I'm going to tie that now into a question from Annie, which is, do you have any recs on what age may be good to wean stimulant, considering potential cardiovascular effects?
That's a good question. I would say I don't have an exact answer, as to what age we start to see an increased risk of adverse cardiovascular effects. But I think I'll answer that in a couple ways. One is on the I have seen, and in my practice, the mental health folks are much more the ones prescribing stimulants than primary care. But having a conversation with the patient as a stimulant is prescribed, that this is not like your statin where you have to take it all the time. If you're going through a time period, let's say you're off work for a sabbatical or something, oftentimes not taking the stimulant during that time period is fine. And you should think of it as something that you use primarily when you really, really need it. And I think that part of why I bring up that phrasing is because as patients retire, that's often when I start to really hammer home, maybe you don't need this for what you're going to be doing now in your day-to-day. That seems to be a great point to think about weaning the stimulant. And then as for the other point, just about all these over-the-counter things, testosterone, all this stuff, I think, again, just repeat conversations about your concrete concerns is the way to go here. I have patients who, for example, with the testosterone issue, which comes up a lot at the VA, I talk to them about it for 2-3 years before they start to really kind of share my concerns. And again, I still think that that's a win if they eventually kind of come around to to being open to deprescribing.
And Adam was wondering, is there an app for MedStopper? That's one of the resources you brought up earlier in the presentation.
I don't think there's an app. It is a pretty old school looking website. But yeah, you can plug in a whole list of their meds, and they, I think you have to take it with a grain of salt that this is a computer program giving you this order of preference for deprescribing, but it sort of incorporates a lot of kind of what that number needed to treat website takes into account. Here's a balance for this patient at this age. And if I'm remembering correctly, you can also check a box off for frailty, balance of harms and benefits for these medications. And then those recommendations, which I find most helpful about tapering regimens.
Lisa had a question specifically related to the ADA guidelines for diabetes, but I'm going to expand it more broadly to a lot of the studies for the talk, which is how are they defining older? I'm talking about older adults, older patients. How are they defining older?
Yeah, and most guidelines don't use any age cutoff. I mean, it's similar to how we think about a lot of cancer screening, right? Where we're really thinking more about our assessment of life expectancy, multimorbidity, cognitive function, and things like that. And so the ADA, I can go back to how they define it. Okay, didn't realize that was so far back. So they describe it, yeah, it's pretty vague, right? Very complex or poor health. And that's a pretty broad term. In their guidelines, they have a few more tips about that. So somebody with cancer that's not likely to be cured, somebody with multiple chronic chronic comorbidities, anybody with an end stage liver, kidney, heart failure type of prognosis. I would add any sort of progressively worsening cognitive function. All of those are sort of how they kind of flesh out this definition. But I would say for us, definitely that sense of trying, it's really hard to prognosticate, but trying to think about your patient's life expectancy, at least in broad terms, decade even or less. And then also thinking about, their general functioning day-to-day, their ADL dependencies, and how much of a burden X, Y, or Z medication is going to place on them. But yeah, usually no age cutoffs there.
We'll have one more question.
Thanks.
Thank you. I really enjoyed this talk. I was involved in a study of deprescribing a few years ago, and the number one barrier that we found was someone else prescribed the drug. And I'm just wondering, you mentioned communication, which seems like a good first step, but any other tips or tricks on how to deprescribe someone else's prescription?
Yeah, I think this is hard. I would say, especially where I have where I struggle the most with this is cardiology medications, because as we all know, like any sort of diagnosis within that realm often leads to 7, 8 medications, all of which can have side effects, interactions, etc. So communication's best, obviously, if you can. Sometimes you're not going to even be on the same page, though, as a specialist about deprescribing that. I think a careful conversation with the patient about that. I think oftentimes, as I'm a primary care provider, I feel very strongly that I understand my patient's day-to-day functioning, their goals, their values, oftentimes more than a specialist who only sees them once a year. So if a patient feels really strongly about deprescribing, let's say, part of their heart failure regimen, and I feel like they fully understand what the potential downstream consequences of that could be, I will consider initiating it with an FYI to the cardiologist explaining. And, I think we forget that there's a number needed to treat for those medications, right, too. And it's not 3, it's, 10, 20, 40. And so not every patient is going to benefit. Most patients will not benefit, I guess, from any individual medication. But I try to do this in a thoughtful way that does at least incorporate that specialist's input. But there have been times when I will, with the patient's consent and full understanding, do this anyway, to be honest.
Dr. Brett, thank you very much for delivering this grand rounds. I feel that often I walk away thinking about what diagnostic test I can order or what new medication I can prescribe, but hopefully taking away from this, I can prescribe fewer meds. Everyone, thanks for joining us today. As a reminder for next week, because it's the third week of the month, for those of you attending in person, Grand Rounds will be located in RC1 in Hensel Phelps. So next week, RC1, Hensel Phelps. Thanks, everyone. Have a good day.
Thank you.